All right, so that finishes up herpes. And now we're going to finish the whole last big chunk of the lecture is talking about HIV and antiretroviral therapy. Antiretroviral therapy refers to the combination of drugs that's used to suppress HIV replication and then to restore CD4 cells and thus the patient's immune system function. So overall with this, what do we want to do, right? Why do we want to do this? We want to decrease morbidity and mortality and improve the patient's quality of life. So this is not curative, but we have come a really, really long way in HIV treatment. And our antiretroviral therapy that we have now has the potential to be extremely effective when used correctly. You'll notice I bolded and underlined and now circled combination. We do not use monotherapy for HIV. We always use a combination of multiple drugs. There are 5 general classes of antiretrovirals, and each different class targets a different viral process. So we typically are, when we give a combination of different drugs, we're targeting numerous different viral processes. Those 5 classes include the nucleoside or nucleotide reverse transcriptase inhibitors or NRTIs, the non-nucleoside reverse transcriptase inhibitors or NNRTIs, protease inhibitors, entry inhibitors, and integrase inhibitors. Now, we use these antiretrovirals, but we also use boosters very frequently in HIV therapy. Boosters include ritonavir, which we already mentioned, and cobikistat, which is another booster. And these are used to increase concentrations of antiretroviral agents. Like we use them with multiple protease inhibitors. And we talked about this with ritonavir. Ritonavir is a really strong inhibitor of cytochrome P450 34A. So by inhibiting 3A4. By inhibiting CYP3A4, you inhibit the metabolism of the agent that's actually working against the HIV. So the ritonavir and the cobikistat, they're not actually killing the HIV, but they're improving or increasing concentrations of the drugs that are, or preventing replication. Initial therapy for HIV typically consists of 2 NRTIs. So NRTIs are really a mainstay of therapy, plus 1 drug from another class. So 2 NRTIs plus an NNRTI, or plus an integrase inhibitor, or plus a boosted PI. Now, when we're choosing agents, we try not to use 2 agents that are analogs of the same nucleotide. So like cytosine analogs or guanine analogs. You don't use 2 cytosine analogs. You want to use analogs of different nucleotides. Here, this is just kind of a summary of combination therapy, initial combination therapy, and then currently available drugs. I'm not going to go through and read this to you, but this is a really good kind of summary where you can come in and try and kind of commit to memory which drugs are which class, because that's really the only way you'll be able to put together a regimen is if you know which drugs are in which class. Again, we use 2 NRTIs plus 1 of the other agents. And then this here is just showing you where different agents work. The picture kind of, it goes down and then this connects like this. And this is showing you the HIV, like what the HIV does, how it enters into the cell, right? Like here you see the HIV fusing the membrane, fusing with the membrane of the host cell. So that fusion is required in order for the HIV to enter into the cell. Well, a fusion inhibitor prevents that, right? It prevents that fusion. And then goes through the whole process of once the virus has penetrated into the cell and it utilizes reverse transcriptase, and then integrase is another enzyme that's necessary in order for the viral DNA to get integrated into the host's DNA. And then as we go down here, you see that the we have this precursor polyprotein, this large combination of proteins that's got to be split up into numerous separate active proteins, and that's where protease inhibitors come in. They stop the splitting of this large polyprotein into individual active viral proteins. I don't expect you to have known that yet. We're going to talk through how all of these work as we go through the lecture. That's just somewhere you can kind of go back to and look at after you've learned it to see, oh, okay, now I see how a fusion inhibitor works. We'll start by talking about the NRTIs, the nucleoside reverse transcriptase inhibitors. These are staples for antiretroviral therapy. And most antiretroviral regimens will have 2 NRTIs in it. So these are really important that you know. Now, these are analogs of different nucleotides. So each one is an analog of a specific nucleotide. And I have down here at the bottom, if you look at where I've got the drugs listed, I have a symbol or a letter for their specific nucleotide. So abacavir, G is guanine, M-tricytidine, C for cytosine, lamivudine, C for cytosine, tenofovir, A for adenine. Okay, I've bolded those first 4 because those are the typical agents that are used. Those are the most commonly used agents. The others are not used nearly as much. So I've bolded those 4 as ones that you should really know. You should be comfortable with those. Now, use of 2 agents with the same analog class is contraindicated. So in other words, you should not use M-tricytidine and lamivudine together because they're both cytosine analogs. Okay, so they should not be used together. It contributes to treatment failure because cross resistance does occur there. The way that I've memorized these key drugs and what their analog class is with the saying, all good elephants can lift conspicuous trunks aloft, right? Picture an elephant lifting its trunk. So all good elephants can lift conspicuous trunks aloft. Right? Abacavir, G. M-tricytidine, C. Lamivudine, C. Tenofovir, A. Okay? That way you know which is which type of an analog, or which analog class. So most antiretroviral regimens will have 2 NRTIs. Also, tenofovir plus M-tricytidine can be used for pre-exposure prophylaxis in individuals at high risk for HIV acquisition. So pre-exposure prophylaxis, we designate it pre-exposure prophylaxis. This is indicated in select populations of patients who are at a very, very high risk for getting HIV. You can give them daily tenofovir and M-tricytidine therapy in order to reduce their risk of actually getting HIV. So it's indicated, for example, with patients who have an HIV-infected sexual partner, people who share needles to inject drugs, people who have multiple sexual partners with unknown HIV status who do not wear condoms. So if any of this kind of class of patients who know it's a risk and are going to continue anyways, or if in case, if you're married to somebody who has HIV, that is a big risk that you are put under. So taking this preventative pre-exposure therapy or pre-exposure prophylaxis can really help to decrease the chances of getting HIV. It reduces the risk of getting HIV from sex by 90% and reduces the risk of getting HIV from injecting drugs by 70%. So that's a good reduction. Obviously, not sharing needles is better. Not having sex without a condom is better. However, this is effective. Mechanism of action, again, these are analogs of native ribosides. What a riboside is just a nucleoside that contains ribose. So ribose, deoxyribose, right? Those are the sugars that are present in DNA and RNA. So a nucleoside that contains ribose is a riboside. So these are analogs of native ribosides, or ribosides that are naturally present in the HIV. These enter into cells, which is kind of key. They've got to get in the cell. They enter into cells and they get incorporated into the viral DNA by a reverse transcriptase. Now, because they're not correct, because they're not the actual riboside, they can't form an appropriate bond with the growing DNA chain, and elongation is terminated, right? You cannot keep producing that DNA. Now, the affinity for host cell DNA polymerase is really low. So they have a much greater affinity for the HIV DNA polymerase, except for mitochondrial DNA polymerase. So the affinity for host DNA polymerase is for mitochondrial DNA polymerase. And this is that right there is responsible for most of the adverse drug effects that occur with the NRTIs. All of the NRTIs are available orally. Zidovudine is also available IV, so that's the one that can be given intravenously. Zidovudine is actually given intravenously to HIV-infected women during labor. If the HIV-infected mom didn't take HIV meds during the pregnancy, or if viral counts are high or unknown. In both of those situations, there's a greater risk for transmission to the infant, right? If the mom didn't take, pregnant women should take HIV medications. There are guidelines based on that specific situation. So if the mom didn't take any HIV medications during pregnancy, or if she did, but her viral counts are really high, or if you just don't know the viral counts, then you're worried about HIV being transmitted to the infant. So if you give the zidovudine intravenously to the mom during labor, it crosses the placenta. And it goes into the infant's bloodstream, and that helps to prevent transmission from the mother to the infant. All of them except abacavir are renally excreted. So abacavir is metabolized. So they're all renally excreted and they require dose adjustment and renal dysfunction, except for abacavir. Abacavir is metabolized, but it's metabolized by non-CYP enzymes. What this means is that these are not subject to many drug interactions, right? They're not metabolized by CYP enzymes. Even abacavir, which is metabolized, it's not by CYP enzymes. So they're pretty easy as far as drug interactions go. There are not very many drug interactions that occur. Tenofovir is a prodrug that gets activated by enzymes inside the lymphocytes. So it's not active until it actually gets inside the lymphocytes. But tenofovir comes in two different formulations, TDF and TAF. TAF results in higher active intracellular concentrations at a lower plasma concentration. So because of that, because the plasma concentrations are lower, TAF typically results in less adverse drug effects. Specifically, we see that it has decreased renal toxicities or renal issues, insufficiency, and a decreased loss of bone density. Which both of these are side effects of tenofovir, which we'll talk about on the next slide. But the TAF has fewer of these adverse drug effects. TDF, though, actually has a better lipid profile. They can increase plasma lipids, but TDF has a better lipid profile. So which one you choose, if you are going to use tenofovir, kind of depends on your patient. If your patient already has issues with bone density, then I would choose the TAF. If they already have, really severe lipid profiles, but the kidneys are fine, the bones are fine, then perhaps TDF. When prescribing two NRTIs, you want to pay attention to the individual adverse drug effects of each one and try to avoid overlapping toxicities. Because the adverse drug effects are not exactly the same in each of the drugs. So, depending on your specific patient, what other conditions they have, you want to pick drugs that have different adverse drug effect profiles. All of the NRTIs can cause potentially fatal liver toxicity. It's typically shows as lactic acidosis, hepatomegaly, and then fatty liver as well. So it is very important to monitor liver function tests and to keep an eye on the patient's liver. With abacavir, it's associated with hypersensitivity reactions that are very serious. And this is relatively common. It happens in about 5% of patients. There's a hypersensitivity reaction that includes fever, rash, GI disturbances, malaise, respiratory distress. And again, it is very severe. There's a genetic test available that tells us if the patient is going to or is prone to have this hypersensitivity reaction or not. So the genetic test tests for HLA-B 5701. So if you're going to put a patient on abacavir, you test for this protein to see if they're going to have a hypersensitivity reaction or not. And then also never re-challenge a patient who has had a hypersensitivity reaction. Didanosine and stavudine are associated with increased incidence of the mitochondrial-related adverse drug effects. They have a higher affinity for the host, so the person's DNA polymerase, than the other agents do. So they have worse adverse drug effects, and they're typically not used because of this. So adenosine and stabilizine are kind of at the bottom of the list because of these adverse drug effects. The increased incidence of things like peripheral neuropathy, pancreatitis, lipoatrophy. Lipoatrophy is what you see up here, where literally like atrophy of the fat tissue. So you see like the fat tissue literally just wears away, and the person gets this kind of skeletal look. They also have all of the other adverse drug effects. So there's still the renal toxicity, there's still the decrease in bone mineral density, but then in addition to that, you see the neuropathy, pancreatitis, and atrophy of the adipose tissue. Okay, so that, those were the NRTIs. Now the NNRTIs, so the non-nucleoside reverse transcriptase inhibitors. These also bind to HIV reverse transcriptase, and they also inhibit the reverse transcriptase. But these are not nucleoside analogs, so they don't bind at the normal binding site. These bind at an alternate site or an allosteric site, and that induces a conformational change or a change in shape of the reverse transcriptase, and then the reverse transcriptase doesn't work anymore. Okay, so the difference between the NNRTIs and the NRTIs is where they're binding in order to inhibit that reverse transcriptase. You see the NNRTIs down here at the bottom. I have the first three bolded because those are clinically used more. Nevirapine and delaverdine, these last two have lower efficacy, so they're not recommended in clinical situations very frequently. Efavirenz and rilpivirine are recommended as initial therapy in certain situations, whereas etravirine is not initial therapy. Okay, so efavirenz is typically recommended as initial therapy in patients with TB, and the reason for that is it does not interact negatively with the rifamycins, like rifampin, right, which is like standard TB treatment. So efavirenz can be given to patients who are also taking tuberculosis therapy. Rilpivirine is the smallest tablet size, so it's good initial therapy in patients who have difficulty swallowing. And this might not sound like a big deal, but because of damage to the mucosa, it actually is relatively common in HIV patients, especially once we've progressed to AIDS. It is common to have trouble swallowing. So if the person has trouble swallowing, and some of these tablets are huge, this one has the smallest tablet size, so might be important. Etravirine is reserved for treatment-experienced patients with multi-drug resistant HIV. Etravirine is effective against resistant HIV, so we don't use it as initial therapy. We hold it back until the virus is mutated and it's resistant to other therapies, and then we give the etravirine. Adverse drug effects vary with each of the drugs. They're different from each other, so they do cause different adverse drug effects. They all, however, have high rates of hypersensitivity reactions, so including things like rash, hives. They all have high rates of hypersensitivity. Efavirenz is not given to pregnant women. Again, I point this out because that's a rarity. A lot of these drugs are given to pregnant women. We recommend that a woman with HIV continues therapy through pregnancy. But efavirenz is one of them that we do not give during pregnancy. Here you see some adverse drug effects with efavirenz, again, not during pregnancy, causes dizziness, vivid dreams, again, hypersensitivity. But the specific adverse drug effects are they're going to be different with each agent, so you'll have to look up the agent individually. Protease inhibitors. Protease inhibitors were big game changers in the treatment of HIV. The number of patients who died from AIDS decreased greatly after the induction of HIV, and they still are. We're making really good strides in HIV therapy, and the numbers continue to decline. Not as fast as they did. They went way down when we started developing more effective antiretroviral therapies. But numbers still are going down. We still are improving therapies as time goes by. There are quite a few protease inhibitors that exist, but there are only a couple that are recommended as initial therapy. And this is just because they either have like a better toxicity profile or a better dosing profile, and they're easier to use for whatever reason. I've bolded the two most common protease inhibitors. And you can really focus on the bolded ones that I've given you from each section because there are just so many drugs that I'd rather have you learn the commonly used ones really well than memorize a bunch of stuff and forget it. So really focus on these bolded ones or anything special that I throw out about a drug. Let's see, the mechanism of action, they inhibit HIV protease, and this prevents the maturation of the virus particles and results in the production of non-infectious virins. They are recommended for use in initial therapy or the initial antiretroviral regimen in certain situations. So we recommend the protease inhibitors in the initial regimen if resistance testing results are not available. So if you don't know if the patient's infected with a resistant form or not, or if adherence is uncertain. If you're worried about adherence to the regimen, perfectly taking the meds when intended, then you're also worried about resistance, right? Because when they don't take the drugs, all the time, when you miss doses, you increase the chances of resistance developing. So we give the protease inhibitors in the initial regimen in either of these situations where we're worried about resistance. And the reason for that is that protease inhibitors have a very high barrier to resistance. There's not very much resistance that develops with the protease inhibitors. So they're good in those situations where you're kind of worried about resistance or you're not sure if resistance is present. Again, protease is that enzyme that cleaves the viral polyprotein into individual enzymes and structural proteins. Remember, we said it's one big protein and then it gets cleaved into smaller active proteins. Protease is the enzyme that does that goes in and lyses the polyprotein into individual proteins. So if you inhibit that, you inhibit the freeing up of those active proteins. Atazanavir and darunavir are the most common of these. You will notice, though, they all end in avir. Taking the protease inhibitor in conjunction with a high-fat meal can have kind of varied effects depending on which drug it is. For example, nelfinavir and saquinavir, their absorption goes way up when you take it with a high-fat meal. Indinavir absorption goes down with a high-fat meal. Some of them are unaffected. My point in telling you that is that you really need to look at the individual drug. Once you decide on the drug, really kind of pay attention to the kinetics of it, and then you can recommend to your patient whether they eat with it or not. Protease inhibitors are potent CYP inhibitors, and they are extensively metabolized. All of them are metabolized by CYP3A4, and then as you look at the different drugs, they're also metabolized by various other CYP enzymes. So the fact that they are potent inhibitors and they're extensively metabolized means that drug interactions will be clinically important. Okay, so you'll need to pay attention to the drug interactions. Adverse drug effects, nausea, vomiting, and diarrhea are common with all of the agents. Insulin resistance and resultant diabetes are possible. Hypercholesterolemia and hypertriglyceridemia are also possible. Protease inhibitors can cause fat redistribution. So what this redistribution pattern is you lose fat in the extremities. So you lose fat in the arms and legs and increase fat in the abdomen, the back of the neck, and the breasts. And the back of the neck results in this buffalo hump appearance. And the fear or patient concern with this fat redistribution is that it's a very visible way for people to look at you and say that you have HIV. So patients are typically very worried about this fat redistribution. Not to mention that's just not fun, right? Nobody wants their physical appearance to be marred in any way. Tiprenavir has some additional adverse drug effects that are really nasty, like severe hepatotoxicity, intracranial hemorrhage. There's a lot of really bad stuff with tiprenavir, so we don't really recommend tiprenavir. Again, I told you guys that with protease inhibitors, drug interactions are very common. Due to the fact that they're CYP inhibitors and because they're metabolized heavily by CYP enzymes. Drugs can accumulate to toxic levels and if given with protease inhibitors and are contraindicated in specific situations. So if you give them with drugs that are metabolized by the CYP enzymes that they're inhibiting, then the drug is going to build up and accumulate because the protease inhibitor is inhibiting its metabolism. So they're contraindicated with multiple drugs that you see here. Some examples here are if protease inhibitors are given with simvastatin and lovastatin, the statin builds up and we see an increased incidence of rhabdo. Fentanyl. If fentanyl is given with protease inhibitors, the fentanyl builds up. Fentanyl is a very, very potent opioid, and that results in increased respiratory depression. If they're given with triazolam and midazolam, they build up and it results in excessive sedation. Okay, so these are all important things. Respiratory depression, rhabdo, like these are big deals. So all of these drug classes and individual agents are things that you'll need to be careful with when giving a protease inhibitor because the inhibitor is inhibiting the metabolism of these agents. Now, dose modification of other agents might be necessary. So things like warfarin, phenytoin, sildenafil, these aren't completely contraindicated, but the dose will need to be changed if they're given with a protease inhibitor. Now, because the protease inhibitors are metabolized by CYP enzymes, if you give them with CYP inducers, that can lead to treatment failure of the protease inhibitor. So drugs like rifampin and St. John's wort, those are contraindicated because they induce enzymes that lead to treatment failure with the protease inhibitor. Okay, so bottom line here is that interactions are highly important with protease inhibitors. So it's something to look out for, to be very careful about, and to caution the patient about, because the patient needs to know they're not allowed to start any over-the-counter medication without talking to you first. And that includes herbs and natural supplements and things that seem super safe. Now we'll talk about the first two of these protease inhibitors in a little bit more detail, since these are the ones that are used the most: atazanavir and darunavir. So atazanavir. Atazanavir is a useful protease inhibitor because it's associated with decreased hyperlipidemia compared to some of the other agents. So if you're worried about hyperlipidemia and you're choosing a protease inhibitor, this is probably a good one to go with. It does require an acidic environment for absorption. So in order to make sure the stomach is acidic enough, we say that it should be taken with food, because remember, when you put food in your stomach, that stimulates the parietal cells to start making more hydrochloric acid. So you take it with food to increase the acidity, and it's contraindicated with proton pump inhibitors. Again, proton pump inhibitors, things like omeprazole, pantoprazole, those are given for acid reflux, and they decrease the acidity of the stomach. They also need to be separated from H2 blockers. H2 blockers, histamine receptor blockers, are also given for acid reflux, but they're not as effective as the PPIs, essentially. So you have to just separate the H2 blocker. Obviously, you can't give the protease inhibitor, or you can't give atazanavir like at the same time that you would take Tums or anything like that. Atazanavir can be boosted with either ritonavir or cobicistat. Now, remember, protease inhibitors are boosted. Like, you boost protease inhibitors. So in this case, it can be boosted with either ritonavir or cobicistat. Additional adverse drug effects that we see with atazanavir include hyperbilirubinemia and possible jaundice. This is not it's not like because the liver is failing, but we do see an increase in bilirubin and possible jaundice. They can also prolong the PR interval, so caution cardiac-wise, and cause a rash. Note, atazanavir is metabolized by CYP3A4, right? That's why this boosting with ritonavir is so effective, because ritonavir inhibits CYP3A4. Darunavir is approved for initial therapy in treatment-naive patients or in patients who are resistant to other protease inhibitors. So atazanavir is in like your normal patient, your initial regimen. But if the patient is resistant to that atazanavir, then darunavir is the drug that you would put them on. But it can also be given initially as well. Again, must be taken with food. And darunavir can be boosted with cobicistat or low-dose ritonavir. So that is an important distinction. Again, additional adverse drug effects include rash and metabolized by CYP3A4, hence the fact that we boost. I'm not going to go through each of these, but this is just a list of the different protease inhibitors and their major adverse drug effects or issues that might go with that protease inhibitor. So as you go down, you can kind of read through each one on your own, but you will see that atazanavir and darunavir are probably some of the most well accepted or well tolerated, if you will. They're tolerated the best, which is one of the reasons why we typically use them. Okay, so moving on from protease inhibitors, we'll talk about the two entry inhibitors. Now, remember that the first thing that happens is that the HIV enters into the cell, right? Viruses are obligate intracellular parasites. They have to get inside the cell to be effective, to replicate. So entry inhibitors block that entry, right? They stop the HIV virus from getting into the cell. Now, they do that in two different ways, though. Enfuvirtide is what we call a fusion inhibitor. What typically happens is HIV gets into the host cell by fusing its membrane with the host cell's plasma membrane, right? And it does this via a conformational change in its transmembrane glycoprotein, GP41. Okay, so GP41, that transmembrane glycoprotein, has to change shape in order for the fusion to occur, for the HIV to fuse with the plasma membrane cell. So what enfuvirtide does is enfuvirtide binds to this glycoprotein 41, and it prevents that conformational change. If glycoprotein, if GP41 can't change shape, the fusion doesn't occur. So the HIV never gets inside the cell, right? And it can't replicate if it can't get inside the cell. Enfuvirtide is used for treatment-experienced patients who have continued viral replication despite therapy. So when you have somebody on an adequate HIV regimen or an antiretroviral regimen, and they still have continued viral replication, it's not effective, it's not working well enough, then you can add this entry inhibitor on. It's given by subcutaneous administration, and the adverse drug effects are mostly just associated with that injection at that injection site. So almost all patients will end up with some sort of pain, swelling at the injection site. Nodules are very common at the injection site, but that's most adverse drug effects are limited to that site. Maraviroc is another entry inhibitor, but it works at a different location, at a different spot. So what Maraviroc does is it blocks the CCR5 co-receptor that's needed for entry into the host cell. If the HIV can't bind to this CCR5 co-receptor, then it can't enter into the cell. It's not able to enter into the cell to replicate. Now, there are multiple different co-receptors, and the HIV that the person has might prefer one versus the other. There's the CCR4, CCR5, or both CCR4 and CCR5 co-receptors. Some HIV likes just the 4, some HIV likes just the 5, some HIV uses both receptors. So before you treat with Maraviroc, you have to test to test their viral receptor preference to make sure that the HIV that they have prefers the CCR5 co-receptor only. If their HIV uses the R4, Maraviroc won't work. If their HIV uses both receptors, then Maraviroc won't be nearly as effective. So you've got to test the receptor preference before starting treatment. Maraviroc is metabolized by CYP3A4, so you need to reduce the dose when it's used with a protease inhibitor. Because remember, the protease inhibitor inhibits the CYP3A4, and you need to increase the dose if you're using it with efavirenz or etravirine, because both of those will enhance the CYP3A4 or induce the CYP3A4. Okay, so protease inhibitors inhibit CYP3A4. So you need to reduce the dose of your Maraviroc. Efavirenz and etravirine induce CYP3A4, so you'll need to increase the dose of Maraviroc. I hope that makes sense. That was a lot of words back and forth. Adverse drug effects include severe hepatotoxicity that's typically preceded by fever or rash. That's important for you to look out for and for the patient to look out for, to know if they have a fever and a rash that they need to, come present to you, because that's could be followed by the hepatotoxicity. Now, that severe hepatotoxicity is rare in general. The Maraviroc is relatively well tolerated, but of course, it is still important to look out for the hepatotoxicity and to monitor LFTs. So that you can catch it early and stop the Maraviroc. Next, we'll talk about the integrase inhibitors. Integrase inhibitors inhibit integration, right? So they inhibit the enzyme integrase, which is needed to insert the viral DNA into the host cell's genome. So by inhibiting integrase, they inhibit the integration of viral DNA into host DNA. Drugs are here at the bottom: raltegravir, elvitegravir, dolutegravir. Notice they all end in tegravir. And look at the name, integrase, right? So tegravir, tegrase, kind of makes sense, right? And vir like virus. Eltegravir has a relatively short half-life of about 3 hours, but when you give it with cobicistat booster and food, that increases to about 9 hours, and that allows us to dose just once daily. So the elvitegravir is typically given in combination with cobicistat. Again, that allows us to dose it just daily. These are subject to chelation with antacids or other cations, divalent cations. So you can't give them at the same time as you give, Tums or Rolaids or calcium supplementation, because they will, they'll chelate, they'll attach to the cation, and then they won't get absorbed. Adverse drug effects are typically nausea and diarrhea, and there is some cross-resistance that occurs between raltegravir and elvitegravir. Dolutegravir has very limited cross-resistance. So if HIV is resistant to one of the other agents, then it is okay to try the dolutegravir instead. Finally, boosters. We've kind of talked about boosters a little bit, and that they are pharmacokinetic boosters. So we use them for their pharmacokinetic profile, not their actual drug mechanism of action profile. The boosters include ritonavir and cobicistat. Ritonavir is actually a protease inhibitor, but it's not used that way. That's not why we use it. Low doses are used to take advantage of its strong inhibition of CYP3A4. Because it inhibits CYP3A4, it's inhibiting the metabolism of numerous other agents. So we combine it with protease inhibitors typically to enhance their bioavailability. We use them in some initial antiretroviral regimens, just depending on what other drugs we're using. But if we're using protease inhibitor, we'll probably be using a booster as well. The ritonavir itself is metabolized by both CYP3A4 and 2D6. Several drug interactions do occur with ritonavir. One, because it's a potent CYP inhibitor. So if you give it with other medications that the patient might be on that are metabolized by CYP3A4, you need to be aware of those drug interactions that could occur. Also, because ritonavir is metabolized by CYP enzymes, it's possible that there could be, drug interactions from other drugs that affect the ritonavir concentration. And ritonavir is primarily a CYP inhibitor, but it does show, or it sometimes shows some, it does also show some stimulation of other CYP enzymes. So it's got a really complex pharmacokinetic profile. Cobicistat inhibits CYP3A4, 2D6, and P-glycoprotein. We typically combine it with a protease inhibitor, either atazanavir or darunavir, and we can also combine it with the integrase inhibitor, elvitegravir, which we just talked about on the previous slide. Cobicistat may be associated with elevations in serum creatinine, so it's important to monitor serum creatinine if the patient's going to be on cobicistat. These next few slides, guys, are not things that I'm actually going to go through with you, but I included them in your PowerPoint for you to use as references. In the notes section of the PowerPoint, I have the link to where this is from. It's from a National Institute of Health website, and it's aidsinfo.nih.gov. And again, it's just guidelines for the adult and adolescent antiretroviral therapy. Here are the accepted initial regimens. I just have here, these are the drugs that are co-formulated together. A lot of these agents come with numerous drugs, like 2 drugs or 3 drugs in one pill. Because compliance is so important, the last thing you want is for your patient to have to be taking, 4 pills in the morning and then, 6 pills at night, and it becomes really difficult compliance-wise. So most of the drugs are co-formulated together with multiple drugs in one single tablet. And then this is the key. Man, this key comes in handy because there's all of these different abbreviations for the drugs. So that's there if you want it. And then, again, I have the website in the notes section for you, but it's really, really helpful to look through. And you'll be using this if you actually are working with, HIV patients, because the initial therapy is highly patient specific. So it's not like you can just memorize one drug and say, oh, this is first line every time. It really depends on the patient. So these charts on the next few slides will just kind of show you that. So for example, like there are pre-antiretroviral therapy characteristics, so like patient characteristics that will kind of help guide you. So if the CD4 count was really, really low to start, and then there's HIV RNA levels. There's HLA-B5701 positive or result unknown, right? If they have HLA-B5701, remember that means that you can't give them abacavir. ABC is abacavir because that's associated with that potentially fatal hypersensitivity. This is showing us other things, so like one pill once daily regimen. If you're really worried about compliance and you want to give one pill once a day, well, here are different combinations that are appropriate. Food effects, right? So there are different regimens that need to be taken with food, regimens that can be taken without regard to food, regimens that have to be taken on an empty stomach, right? And this all could possibly be important. You never know when you're going to get a diabetic patient who comes in, who's on insulin, who has to eat very regularly if they don't want to bottom out, and they're not able to, wake up in the morning and take the medication on an empty stomach and then wait a couple hours until eating. So you never know when you'll run into a very specific situation. Here we have, appropriate regimens in patients with chronic kidney disease, liver disease with cirrhosis, patients with osteoporosis. So with osteoporosis, avoid TDF, right? Remember, tenofovir has TDF and it also has TAF. Remember, TAF is less osteoporosis. There's less loss in bone mineral density. TDF has a lot of loss in bone mineral density. So there's all different situations that can help guide you in therapy. At this point, I want you guys to remember, the most common drugs in each of the classes and key points about them. And then if you know those key points, you'll be able to understand these guidelines when you read them. I don't expect you to memorize the guidelines because there are simply too many options. I just want you to be able to understand them, right? Like understand why we would avoid TDF in this specific patient. Understand why we would check for the HLA 5701, okay? All right, I know that was a lot, so thanks for bearing with me. If you guys have any questions, shoot me an email, and I will see you guys on Friday.